kind of umbrella things that we deal with, and one of them is symptom management. The big ones are like pain, nausea, vomiting, those sort of things. And then the other umbrella is kind of goals of care discussions, difficult goals of care discussions of people with terminal illnesses.
We want to know what your goals of care are, what your wishes are in regards to your treatment. How aggressive do you want to be? Is it time for care and comfort? Do you understand your disease progression? Do you understand the treatments and the therapies? Is this clear to you what is happening to you? Patients that come in with life-limiting diseases, life-altering diseases, multiple comorbidities, frequent hospitalizations, complex medical care is often when palliative care in the hospital setting is called in.
Triggers for me for bringing it up, recurrent hospitalizations is often a moment where we take a step back and say, okay, let's talk about the quality of life that's important to you. Is it okay that you're coming into the hospital every few months? What bothers you about that? And sort of start to have conversations. I think when somebody is having a lot of issues with symptom control despite being on the maximal medical therapy that I can offer, right, which happens often, I think that's an appropriate moment to offer and to talk about.
If anything, refer early when we can make a difference, because we can help with a lot of the suffering that people have early on, and it'd be better to get us in early than late.
I'd rather have somebody put in a consult for palliative care, and then we say, you know, we met with them, they're okay. You know, they're going to fight this disease, they've got their teams set up, you know, they know what their wishes are, and we'll see them again at another time. But I'd rather have you put in the consult and let us visit or review and see what that patient might need, rather than wait till the 11th hour, because we really cannot do the work. And the same with hospice care, but palliative care especially. We cannot do the work when you want us to come in and the plan is to discharge tomorrow. You know, that it doesn't benefit the patient, and it certainly doesn't benefit us either in regards to getting our work out there and knowing all that we can offer to these patients. So early referral is huge.
I mean, if in a perfect world they would go hand in hand, you know. I think you would have a diagnosis of something like that, and at the same time you'd be introduced to palliative care at that time. I think the problem that we get into sometimes are people are introduced to it too late, when it's when there's a very short amount of time left, and you know, the things that we can do to help benefit people is limited. So. Hospice care is a type of palliative care for the nearing the end stages, but I try to think of palliative care as coming in much earlier in the trajectory of a person's illness, when we can help with symptoms and things, and potentially even getting involved when somebody has a potentially life-threatening illness, but there are curative measures that can be involved. One of the biggest barriers is knowledge of what we actually do, and in fairness to providers, it is a little bit nebulous what we do. So, but I think one of the big barriers is just an understanding of what palliative care is. I think it's a relatively new specialty within the field of medicine, so some providers aren't comfortable with it or don't understand.
And I think maybe one of the other parts to it is that they're very, very focused on life-saving. And I think they're maybe a little bit afraid that we're going to come in and start discussions on care and comfort versus they're still in this fight for their life. I think that happens a lot, possibly with patients that are battling cancer, is that we can be working side by side with the oncologists. I'm not going to jump in and all of a sudden say, this treatment isn't working, I think that, you know, you should stop the treatment and let's go care and comfort and, you know, put up all the comfort medications and take you to the end. We can come in at the same time with oncology so that they have a support team either in the hospital if they come in, or even when they go out and outpatient, you know, they have someone that's kind of following them as well as the oncology team.
Large barrier would be the patient's acceptance and the family's acceptance to palliative care. They hear palliative care, they automatically think, oh, palliative care is just one step to hospice. What do you mean? Am I going to die? Does this mean that this is the end for me? And palliative care is not, it's not there. It's not necessarily just for patients who are ultimately going to end up on hospice. But there's that misnomer, and I believe patients feel that they don't fit that criteria. So even if we introduce it, a lot of patients don't accept it, or they say, you know what, I'm fine, I'm functional, I'm able to move around, I can manage these symptoms by myself without additional help.
I think the patient barriers are more, are the same as some of the clinician barriers. I think they don't understand what it is. I think when we get consults, we spend a lot of the beginning part of the consults with some people describing what palliative care is and how we can benefit people. Another barrier, I think, is sometimes denials. People think they don't want to believe that their illness is life-threatening, and us getting involved is kind of an acceptance of that, and they don't want to accept it sometimes. We're lucky in Boston because there's a lot of access. And that access doesn't exist in a lot of places of the country, so we can do a lot of stuff here. When we kind of commiserate with our palliative care buddies in other parts of the country, they can't do all the things we can do here in Boston.
Education. Absolutely. We try to go around and educate them as much as possible. There are new hospitalists that come on board. They don't know anything about palliative care. We love when they consult us because I recognize them as a new team member, and I immediately start right off, you know, educating them on how we can help them. And I think it's wonderful to see when they see something that we've done to help manage a symptom, and it actually made the patient brighter, and they're eating better, and they're more alert, and they're now participating in physical therapy, and now they're going off to rehab or home. And I think that they see that as successful, and then I think the bell kind of goes off that we can help in a number of ways.
The other part is, I think that people learning, new nurse practitioners, new residents, whatever, I think they have to develop their own primary palliative care skills too, so that and then realize that there's a lot that people can do on their own, and then for the more challenging cases, or when a little more support is needed, that's when and how to consult us.
The way that I generally approach patients when I want to introduce palliative care or end-of-life care is I would tell patients that it's not giving up on their treatment, but it's to enhance their experience on that particular chemotherapy treatment, or if they're not on any treatment, to enhance their life and to enhance the quality of life specifically.
Whatever services are offered to you, I would take it first, then decide what you need. I would also ask questions. Make sure, and you may not remember it at the time, and when you go home, you write it down, you ask questions, and then you say, who's going to best help answer this question? If there is a case manager, if there is a nurse manager, whoever kind of is a coordinator of your care, keep that contact person so that you can ask the questions to find out then who else out of those resources is best able to help you through that problem or the question.
Well, I think that there is no such thing as talking about end-of-life wishes or advanced care planning too early. I would advocate for everybody thinking about it, no matter how young or old you may be. As an example, my mom is, this very no-nonsense woman of few words. And I assumed that she might be the type of patient who would say, you know what, when my time comes, my time comes. I don't want any of this craziness, or any of this hullabaloo. I'm not saying it's craziness, but the kind of people that would put it like that. But actually, she said, you know what, as long as I can read, I will be able to have a quality of life that's okay for me, right? And it's totally different sort of vision of her, so that if, God forbid, I get a call from an emergency room, I am so much better equipped to make decisions for her with just that one conversation.
The thing we often hear is people say, we don't want to talk about it because then it's going to happen, or we don't want to talk about it because that my mother, father, brother, whatever, will lose all their hope. And actually we know that the opposite is true from research, is that there's less rates of depression, anxiety, and things like that when you actually talk about it, and there's less bad things happen to people. There's less deaths in the ICUs. There's less deaths with aggressive management being done on people. So I think it's important because we have to talk about what people want. Otherwise, they get things that they don't want.
It's not a one-time conversation, so it will happen in little bits over time, and I also don't think it has to be right from the get-go. Do you want to be resuscitated? Do you want to be intubated? It's about so much more than that. I think it's just important early on for the people in that relationship, the patient, the provider, the family, that they start to be able to identify what's important to the patient, what matters most.
I love when I've really gotten a relationship going with somebody. I love when I've taken them to the point of being really anxious and confused about a new diagnosis or an escalating disease, and I've brought them to a much more comfortable level with their disease. It's not always, I certainly can't cure their disease, but I like when they are comfortable talking about it. I also love when somebody has made their own wishes known. I love when they truly understand, I don't want that done anymore. And they understand life-sustaining measures, and they're able to say with confidence, that does not sound like something I want. That's when I'd either rather be let go, or yes, I want to fight that.
I think we're kind of fast-tracked to into people's lives in a way that I would never be allowed otherwise. So these people are going through these very emotional, very troubling, difficult times, and we can really make a difference at that point in time. And then the other part too is a tangible part where people are having a lot of pain, and you can do something about that almost instantly. That's a good feeling.
And then on kind of the sadder end of it, when somebody really is at the end, and sometimes palliative care takes them to the end, it's nice when you can see a family kind of come full circle and they've accepted, and the patient is accepted to a certain degree, that they're going to die, and you've brought in the right family members, and people are all present, and they've been kind of able to mend whatever fences they can and just be present and really help somebody towards that end.